Now, obviously, we don't have the ability as a society to pay for everything for everyone who might benefit from it. Clearly, there are limits. And it is within this floor that we have to come to terms with our limits as a society. It's within this publicly financed floor that we're going to have to make decisions about what we will pay for and what we won't pay for, instead of simply pushing the bill onto our kids' credit cards. So the fundamental challenge we face here is not how we get more money to pay for health care, but how do we ensure that the public dollars we're already spending on health care are allocated in a way that benefits all of us, not just some of us, and that we actually get a population health benefit for this huge and growing expenditure. Now, unfortunately, that's not what's happening today. The national political debate around health care is not focused on creating a system that improves the health of Americans, but rather on finding out how to pay for the system we already have. The debate in Oregon and in California, the proposals of both McCain and Obama have defined this as a financing problem, and they're focused on how everybody can get access to health insurance so they can buy into the current health care system. Now, Dr. Don Berwick, who's the president and CEO of IHI, has this wonderful, robust analogy that captures, I think, the essence of the problem. Don says that he compares the efficiency of a car to the efficiency of our healthcare system. So every car, as we know, has a maximum speed. You can take your new Porsche, your Prius, your old GMC pickup out to the Bonneville Salt Flats, and you put the pedal to the floor, and pretty soon it's going to get going as fast as it's going to go. It's going to reach its maximum speed. Now, if you don't like that, what can you do? Well, you can yell at your car. You can file an incident report, you can give it an incentive. It's not going to work. Because the maximum speed is a function of the car. It's built into it. By the same token, the inefficiency and poor performance of the U.S. healthcare system is a function of the system. It's built into the system, and that's not going to change by simply changing who pays for it. Now, to understand that, we just have to look at two things. First, those things that have the biggest impact on people's lifetime health status, and secondly, where we spend most of the money in the U.S. healthcare system. If you look at the factors that influence people's health, you will notice that 40% of our lifestyle and behavior, 30% are genetics, who your parents were, 15% are social factors, whether you have a job, your income, housing, the ethnic and racial disparities in our system. Only 10% have anything to do with involvement with the U.S. medical system. So in other words, 90% of what affects lifetime health status doesn't have anything to do with modern medicine. We don't have a health care system, we have a sick care system. We're real good at coming in on the back end, we're not very good at keeping Americans healthy. Now, if we look at where the money is spent, we'll discover that 70 to 80% of the dollars in any given year is spent on people with one or more chronic conditions: diabetes, heart disease, asthma, mental health issues, etc. Furthermore, the distribution of those expenditures across the population is very, very uneven. In any given year, 1% of the population consumes 35% of the healthcare dollars. 10% of the population consumes 70% of the healthcare dollars. Now, you all remember Willie Sutton, the bank robber in the 20th century, who, when asked why he robbed banks, infamously said, because that's where the money is. So if we want to figure out how to fix the healthcare system, it would behoove us to look at where the money is. Now, we know some things about chronic diseases. First of all, we know that they're progressive. They start out at a very low level, and then complications accrue. And if those complications aren't dealt with immediately and appropriately, they get worse, requiring more interventions, poor outcomes, and more expensive treatments. Secondly, we know how to prevent those complications. We've known it for a long time. The problem is that it requires a certain type of delivery model. It requires physicians who actually work with each other as a team, and along with non-physician providers who communicate with each other, who provide information about that patient with each other. It requires well-educated patients who can recognize the early signs of a complication. So if you have congestive heart failure, and you wake up one morning and you weigh 2 pounds more than you did yesterday, that's a sign you're going into failure, and someone needs to know about that. And you need a system that responds rapidly and does the right things to keep you from progressing. Unfortunately, our delivery system was not designed either to prevent illness or to manage chronic conditions. Like our financing structure, the demands on it have changed over the last 50 or 60 years, but the system itself has not. First of all, our system evolved around what I call an acute care infectious disease model. Episodic medical interventions of high intensity, treating a stroke, treating pneumonia, treating a broken hip. Most people traditionally don't go to the doctor when they're well. They go to the doctor when there's an acute episode that they need taken care of. Now, that makes a lot of sense for acute life-threatening conditions that you see in the ED, or for non-life-threatening acute conditions like a bladder infection or a sore throat. The problem is that this has become a de facto one-size-fits-all delivery model in the face of very different delivery challenges, one of which, of course, is chronic disease. Secondly, doctors actually don't work well together. Doctors still practice mostly by themselves or in small groups. Less than 4% of physicians in this country are in groups of more than 50 physicians. Doctors are cowboys. Trust me. They don't work well together, which creates a real problem. The average individual with one chronic condition has 5 to 8 physicians taking care of them. And if they don't coordinate that care, you get drug errors, you get a whole host of interstitial problems and terrible, terrible outcomes. And finally, as some of us were discussing earlier, there's no good data in our healthcare system. Most of the information about patients is locked up in paper records in hospitals and in doctors' offices across the country. And even if you have an electronic patient record in your practice, it may not be interoperable with those in other practices of physicians who are also taking care of that patient. So this inability to have data that can be aggregated and computerized and tracked prevents medicine from having the kind of continuous process improvement that is a hallmark of almost every other business in America today. And finally, we have a set of financial incentives that actually reward acute care interventions and discourage reorganization around chronic care. There are 9,000 different billing codes to which hospitals and doctors get paid, but there's no code for a cure. Hello? There's no billing code for prevention. There's no billing code for health improvement. They are not billable events. So as a result, the entire infrastructure and all the infrastructure decisions in our healthcare system are driven by these revenue streams that reward acute care interventions at the expense of chronic care management, prevention, and wellness. Now, obviously, this is not a system that can achieve the system objectives we talked about no matter who pays for it. My point is that to address the healthcare system requires transformational change. Change that cannot be accomplished by operating within the context and the constraints of incrementally tinkering with the deeply flawed financing and delivery structure. So let me offer you what I believe have to be some of the key elements of a system that can actually deliver the triple aim. First, we need a more equitable and sustainable financing system. I think we need to eliminate categorical eligibility and replace it with a publicly financed floor with eligibility for a public subsidy based on financial need, not on a set of arbitrary categories that came out of the middle of the 20th century. But because of fiscal limits, it also requires that we produce a defined benefit through a transparent public process through which health services are prioritized based on the relative effectiveness of improving health of the entire population, which is essentially the process we've been using for about 15 years in the American health. Now, this basic floor could serve as the basic benefit for everyone, which is administratively most efficient, or it could be just for people below a certain income level with sliding scale subsidies that would go down as income goes up. Secondly, revenue needs to flow to risk-bearing entities organized at the regional and local level, each of which would assume financial risk, but also the responsibility for maintaining the health of the defined population. Now, those entities could be a hospital with an affiliated physician group, a large primary care group. I suppose it could be a visionary insurer or a health plan or an entirely new entity. But what's key here is it serves as a single point of contact, a case manager, an advocate for everybody in that defined population. Payment would take 3 forms. First, a monthly or annual subscription payment that's dedicated to maintaining this relationship with the people who are in that defined population. It includes patient education, maintaining the EMR, individual case management, office visits, etc. Secondly, a bundled, risk-adjusted payment for complex conditions, especially those requiring hospitalization. And finally, an annual performance bonus payment for high-quality care, improving the health of the population, reducing complications, hospitalizations, etc. Finally, and very importantly, this new financing and eligibility structure has to include value-based cost sharing, in which co-payments are used not simply to shift cost to individuals, but rather to try to drive and change individual behavior and personal accountability within the context of the system objectives. So you would have very low or no cost sharing for services that are highly effective, or which rank high in terms of population health, and higher co-payments for discretionary elective services or services that rank lower in terms of producing population health. So for example, you may have no co-payments whatsoever for vaccinations, for well child care, for screening for prostate cancer, or for mammograms, or for the drugs needed to manage chronic conditions. Because you don't want any financial barriers to get in the way, because the return on investment is so great and the cost is so great if they can't access those. However, services that have less evidence to support their efficacy, surgery for low back pain is popular in Oregon, or prostatectomy for benign prostatic hypertrophy, maybe a 50% copay. And then finally, if a family, let's say, wants to get an ultrasound to determine the sex of their unborn child, when the ultrasound is not indicated in terms of a normal pregnancy, they can get that too, but they have to pay the entire tab out of their own pocket. Value-based cost sharing is very important because it recognizes two things. It recognizes the reality that people with more money can always buy more things, including health care, than people with less money. And secondly, that we will inevitably have at least two tiers based on income. But there should not be a qualitative difference between those two tiers in terms of health outcomes. Now, obviously, what I've described doesn't even remotely resemble what we have today, and moving to that kind of system poses a huge challenge because of the huge number of economic stakeholders involved. And the list is a long list. You've got the uninsured, but all those workers who have good workplace-based coverage, seniors on Medicare. You've got employers large and small offering coverage, not offering coverage, doctors, hospitals, Jamaican faith healers, you've got the drug companies, medical device companies, the list goes on and on. So if we want to solve this politically, we've got to recognize that today millions of people's jobs depend on the current dysfunctional structure of the U.S. healthcare system. It is a fact. 1 out of every 11 jobs in our economy is in the healthcare sector. 1 out of every $7 in our economy is in the healthcare sector, and no one's going to willingly give up their job. We also need to recognize that there's a lot of trapped equity in the current system. Hospitals across America are building things, mostly cancer centers and heart centers and imaging centers because they get reimbursed really well. Doctors are investing in the same thing, freestanding ambulatory care centers. Some doctors are getting paid a lot of money to do things that are on the flat side of the population health curve, for which there's no evidence to support their efficacy, and nobody is going to simply walk away from that. So the point is, it is not only politically impossible, it's economically impossible to move from where we are today to a new system overnight. It's going to take us 8, 9, 10 years. There inevitably is going to be a transition period. Now, the practical political challenge that we face is represented by this graph that shows economic burden on the stakeholders here and time over here. If we can agree on where we want to end up, the objectives and the parameters of that new system, and if we can move from our current system to the new system, and the economic burden on all the stakeholders goes down during the transition, the politics would be easy. We would have done it a long time ago. The problem is it looks like that. To move from where we are to where we need to be, there are going to be stakeholders and institutions that are going to suffer economically during that transition period, and all of them have the ability to jam up the political process and prevent anything from happening. So to successfully put together the politics of reform, we have to shift the focus of the debate from where we want to end up to how we get there, to how we manage that transition. And what I've tried to offer you this evening, very quickly, has been the key elements necessary to actually create that kind of system that could produce the triple aim, the results that we want. So our challenge is to make the politics of this transition explicit by legitimizing and acknowledging the economics involved, and by shifting the focus of the debate from where we want to end up to how we get there, which changes the political question from how a given economic stakeholder is disadvantaged in the short term to how together we can mitigate the economic impact on all the stakeholders as we move the current system to a system that better serves the needs of our nation. But without first agreeing on where we want to end up, there is simply no political pathway by which to get there. The Roman senator Seneca once said, "No wind is a right wind if you don't know what port you're sailing for." Now, unfortunately, there is no evidence that this vision is going to emerge from our current political process, which means it has to come from outside, from folks like you and me, and get driven back into the political process. So let me quickly run through how we might go about doing this, and we can talk about this a little bit more when we're done. First, we need to remember the problem we're trying to solve. I'm sure most of you are familiar with Six Sigma, the database methodology that measures error rates in processes. A company operating Six Sigma has 3.4 errors per million. Most medicine today in America operates between 1 and 2 sigma. That is an error rate that would be absolutely unacceptable in any other business in the United States of America. So let me use heart disease to show how this plays out every day in the healthcare system. We know that lifestyle contributes as much as 80% to the development of heart disease. So right off the bat, we have a system that provides no incentives whatsoever to prevent heart disease, and every incentive to treat it after it happens. Secondly, congestive heart failure is the most common hospital diagnosis for people in Medicare. But fully 40% of those people return within 90 days after they've been discharged with congestive heart failure, even though we know how to reduce that by as much as 80% by proper management. My point is this is a system problem, not a financing problem. And simply finding more money to pay for the current system is not going to get our nation where we need to be. So meeting this involves 3 key steps. The first step is the most important one, laying the foundation for reform, and that involves agreeing upon some system objectives, needing an accurate diagnosis of the problem, that is why the current system isn't meeting those objectives, and finally, a clear description of the design elements necessary to achieve those objectives. That's what I've tried to lay out for you this evening. This step has been hopped right over by most healthcare reform efforts at the state and national level today. Secondly, we need to manage the transition. We need to recognize that we can't achieve these objectives through a simple regulatory approach. We need to intentionally engage the economic market, and particularly entrepreneurial capitalism, to help design an entity, an enterprise that becomes ever more profitable by promoting wellness and prevention and reducing avoidable acute care. We also need to make the politics of the transition explicit by beginning to have a conversation about how the various stakeholders will redesign their business plans to prosper in the parameters of the new system. And finally, we need to develop on-the-ground test sites. So supposing you have a hospital with an affiliated physician group that wants to transform itself into a system that reflects those objectives and those parameters, they will immediately run into a series of statutory, regulatory, and structural obstacles that will prevent them from getting from here to there. But exposing and highlighting those obstacles gives us the ability to produce a clear comparison between the current system and the new model, and gives us the opportunity for a very clear, specific avenue for legislative redress. And we can discuss that more if you like. Okay, so let me wrap this up so I stay within my my allotted time. Albert Einstein once said that you can't solve today's problems by using the level of thinking you were at when you created them. That's pretty much where we are. But I like the way the late Western novelist Edward Abbey put it, less eloquently but far more succinctly, when he said, "Society is like a stew. If you don't stir it up, you get a lot of scum." Our job, my friends, is to stir it up. Our job, it seems to me, is to accept the fact that the responsibility to fix this system, and our energy system for that matter, doesn't belong to somebody else. It's not going to happen by itself inside the Beltway. It's not going to happen in Sacramento. It's not going to happen in Salem, Oregon. It's going to happen because of the engagement and commitment of people and communities all across this nation. This is something we can do, and I think it's something we must do. And if we're not willing to do it for ourselves, we should do it for our kids and our grandkids. Give for the future. For those people who, on our current trajectory, are going to inherit a staggering burden of debt. And this dysfunctional system that we put together on our watch, and through our inaction, we are allowing to be perpetuated. Let me just close with the words of Oregon poet Kim Stafford, who far more eloquently than I captures, I think, the opportunity and the challenge, but also the responsibility of what faces this year, and what he calls Lloyd's story. It's a true story. Lloyd Reynolds, the international citizen of Portland, spent his last days silent, unable to write or to speak, lying in a hospital bed. On his last day at home, as his wife scurried to pack his suitcase for the hospital, Lloyd made his way outside in the garden, and there she found him on his knees, awkwardly planting flower pots in the snow. "Lloyd," she said, "you'll never see those flowers." He smiled at her. "They're not for me, they're for you. Salmon coming home, they're for you. The calls of the wild geese, they're for you. The last old trees, they're for you and your children, the seventh generation. But all blooming here. That's our challenge. To plant the seeds of tomorrow. To change the context and the parameters and the terms of this debate. By acting and by leading and by personally committing ourselves to it. Not as victims of the past. And not as captives of the status quo. But as the proud architects of the future. Thank you very much.